You're absolutely right. I mean, there are other options. There's a better option. And in my mind, for today and for this player, it's an OATS, an autograph OATS. So we're going to push through. Let's see here. I clicked. There we go. Disclosure is not relevant to this. So what's special about the ankle? We understand the differences, the pathology, the architecture, and how the access to the ankle, and also the natural history. As Dr. Baumhauer eloquently stated, in regards to addressing all the other pathology that could be going along with this osteochondral lesion, we want to make sure we address that. But as we get to this cartilage lesion, we want to be definitive. So we think about the architecture. The cartilage thickness, as was mentioned, the knee is 1.9 millimeters, the ankle is 1 millimeter. Some differences, but we now know through some great studies that have been done where to essentially harvest for a successful OATS. Concerns with malostimulation. Fibrocartilage is biomechanically inferior to type 2 cartilage. It progressively degenerates in response to mechanical loading of the joint. Many of us have gone through this, and the patient comes back in after our simple microfracture. We know it's likely failed and started to deteriorate, and we become somewhat concerned. So that's when my mind goes toward the OATS, but I would like to avoid that discomfort and come out of the gate with that in some cases. So if we look at the background, microfracture showing less effective treatment for large lesions. With that in mind, if it goes greater than 150 millimeters, this number it continues to be inspected and evaluated and published on, and even creeping down in regards to what we consider a large lesion. So if we talk about the osteochondral autograft, it involves transplanting one or more tubular units of the cartilage and bone harvested from the ipsilateral knee in my hands. And the mosaic plasty is also an additional form. Polycystic lesions are secondarily after failed index procedures. Some primary procedures as well. And in this case, I would go with primary. So if we think about the autograft, it's an inherent advantage, includes replacing the defect with viable hyaline cartilage. And when we look at the biomechanics of an autologous osteochondral transplantation, it has done well and performs well. When we think about, again, placement of the graft, we want this to be as congruent as possible. Somewhat of a quick advance, apologies there. And when we think about, again, the mismatch, that can be the major issue. So you want to be mindful of this during your technique. And so you want to err on the side of slightly countersunk as opposed to proud, as we would do as this has evolved with our techniques. So good medium to long-term outcomes. Systematic review has shown the clinical success in 87% of cases, with donor site morbidity of 12%, as our technique of donor harvest has actually improved. I believe those complications or those symptoms have actually declined, as indicated here in this study by Haggerty, showing 3% donor site pain, and also good outcomes with Moravsky et al. In cartilage. So we look again at these outcomes, and this is why I would approach this with this athlete. If we look at 38 amateur athletes and professional athletes had a large lesion, mean follow-up 45 months, 87% return to play, strong correlation with MoCAR scores and ability to return to sport. 2 patients had donor site knee pain, and in both of those scenarios, they had a large lesion that required more to be harvested. Again, if we think about the single versus double plug, I'm always doing my preoperative planning, mentioning to the patient that we may actually take more than one plug and to whatever we can do to have the best fit and fill and get the best results. As we look at the osteotomy concerns, many of our, we talk about access. I perform a number of plafondplasties now and avoid the medial malleolar osteotomy unless I do need it for exposure. But even in that case, when done technically well, the complication rates are low. 94% of patients asymptomatic in this series of patients, and T2 mapping results showed very good results. So cysts are a concern, or are they a concern? If we really look back at the impact of a cyst after an OATS with clinical outcomes, it may not be as much of a concern as we've previously identified or felt, particularly in the athlete who's getting back for a period of their career. And so with these 37 patients with MRIs 15 months after surgery, 65% had cysts, but the clinical impact was minimal, very short term at all. So this is a case of mine where I actually had a 19-year-old soccer player, large lesion, OATS, autograph 9 months later, back to sport, minimal knee pain. So that's my approach. Thank you.